playfulness and curiosity.
This new superpower called persuasion.
They're the rules of the world, and then here's the rules for us.
What does rich mean?
Stories and wisdom.
Welcome to the Stories and Wisdom podcast. Today we are joined by Dr. Joy Ballsbury. Joy, as I know you. You are a psychiatric epidemiologist, health educator, associate professor for neurology at the Washington University School of Medicine. What's interesting, of course, Joy, is that your work sits at the heart of community-engaged research, and you bridge academic medicine, public health, and the lived experiences of communities that have historically been excluded from research and healthcare decision-making. I know that's very core for you. And your work focuses on health equity, patient engagement, and improving outcomes for populations at risk of preventable premature death. You're also a national speaker, educator, consultant, and advocate for diversity in research and medicine. So, Joy, with that, when somebody asks you, what do you do? Where do you begin?
I usually tell them that I'm a public health researcher because it keeps it simple. And then if they ask for more, I'll tell them that I'm an epidemiologist and that I'm actually in my father's field. My dad was a public health person. He had degrees in biology, PE, and public health, and I actually followed in his footsteps. So I tell them that I like to advocate for communities in which I'm a part of, because I've even had times in my own life where I've been overlooked for appropriate health care. And so I start there, and then I sometimes will tell people, well, I'm an epidemiologist, and they say, well, what is that? And I'll always say that I count and sort really well for a living, that I look at different diseases and epidemics, and that's what I do as a public health practitioner.
Great. And let's go into our first segment because you already brought in your father and then where you started. So it's called Memoir Moment. So we rewind back for a moment to understand where your perspective or how you're looking at this took shape. So can you talk us through an early experience in your life, community, or even training that shaped you to think the way you do?
So I'll start back to early 80s when I was a little girl. I don't lie about my age. I'm in my 50s. And my dad was health commissioner over in East St. Louis, Illinois, which is an area within our country that was ridden by health disparities, violence, and other things. And we lived on the Missouri side. And so one morning, he would comb my hair in the morning to get me ready for school, which was really unheard of for dads doing that. But my mom was a school teacher. And so with her having to go into work by 7 a.m. and me not having to be at school until 8, my dad got us ready for school. And this particular morning, Bryant Gumbel was interviewing on the Today Show a group of researchers in New York about the AIDS pandemic. And the first AIDS case was just found. And my dad, in combing my hair, he kept telling me, will you please be quiet just for a second, because I know I'm going to have to answer questions and possibly be on the news about this later. And so afterwards, we had a conversation about what the news story was about. And I was like, I had to be about 5 or 6, maybe 7. And so our family trips and sometimes our vacations were around going to the American Public Health Association meeting or me attending things with him. And so early in my career, I thought I was going to go to med school. That was the goal. That was what I was planning to do. But I live every day with dyslexia and ADHD, and I struggled with testing. And so I got my master's in epidemiology after doing early disease investigation for the state of Missouri and the city of St. Louis, full circle moment for babies that were born to HIV positive moms to make sure that the mothers were receiving the proper care that they needed during labor and delivery. And my job in basic epi was to, and I didn't really know that it was epidemiology at the time, which sounds really silly now that I know what it is, was to go to different hospitals and read medical records. So I did medical record abstraction. And it was glowing to me that mothers of color, Black, brown, Asian, Hispanic, even those who had ethnicities that were Hispanic, were not receiving the same care of women who self-identified as being white. And how do you conceptualize that as a 20-something? I was like fresh out of undergrad and I didn't understand. I was like, well, why aren't they getting the care that they need? Why aren't they receiving the medicines that they need? And these were the babies that were testing positive also that were born of these moms. And so that led me into getting my master's at WashU. I'm a graduate of Xavier University of Louisiana for undergrad. I'm a big proponent of historically Black colleges. I'm third generation HBCU grad. And my dad at one time, very early in his career, was faculty at WashU. Again, very full circle moments. And when I started my master's, it was in the HIV space, working with women who were at risk for HIV. And I think that shaped me because then it led me into moving to California and working at UCSS as an epidemiologist. It led me to doing some work in Uganda. And then when I decided to go back and do my PhD, the person that I wanted to train with did research on guns and tobacco. So I had to switch. And so that meant that I needed to start really thinking about how do we engage all populations and communities in dialogue about health when we're disease agnostic? And basically what that means is sometimes the same factors impact a person regardless to if it's a chronic health condition or if it's infectious disease in terms of access to care. And so those moments were very pivotal to me, asking the questions of, well, why does this disease exist? Asking the questions of why certain communities were not receiving the care that they needed, regardless to race, gender, or otherwise. And then knowing that my dad was in the forefront of fighting for communities that were voiceless, I wanted to be a part of that legacy.
Wow. There were stories within stories within stories in what you shared, and that's consistent with what I know about you. But there's so much depth and layers to your path that you're sharing. Like on one part, I feel like, of course, you were going to follow his footsteps and you had all these moments. But on the other side, there was also so much of this, you're just open for exploration, discovery, and it took you there. And when you look back, how do you see this? Was that like, this is the path, obviously, because it's been trodden with my dad, or I explored and I ended up there? Like, how do you tell the story now looking back?
So really funny. When I worked at the health department, I did not like bureaucracy. I didn't like going to work at a certain time of day. I liked more flexibility. And I think part of that is because of the ADHD. And so, I wanted a little more flexibility. And I remember working at the health department in the late 90s and my dad being like, yeah, I hear you're always getting to work late. And I was like, well, yeah. So I started planning my day when I could do medical record abstractions at a certain time so that I could leave for work later. And I realized after working at the University of California, because it wasn't only HIV, we did hepatitis stuff, we did some evaluation work and some other things. And I loved the flexibility and the creativity that science brought. And I remember telling my dad, I was like, I actually love this. And he was like, really? And I was like, yes, I do. And my girlfriends would always joke if somebody would do their job for free, it would be Joy. But I do need to eat and I like to shop and I like other things too. So yeah, some aspects of my job I'll do for free, but I'm also have a mortgage. So I have to think about those things. But I actually, working as an epidemiologist at UCSF before I did my doctorate, I did a post-bac program at San Francisco State and I dropped out of the program. It was for non-traditional students who wanted to go to med school. And I was struggling because here it is. I loved on this one hand doing basic epi and being out in the community and talking to people about their risk, but with larger populations of people. And I was seeing things in the clinical side in terms of some of our work was in stomatology, which is diseases of the mouth. I was liking those one-on-one interactions with patients, but I was also liking those bigger groups and engaging with them. And then I was going to classes and trying to figure out what the hell the Krebs cycle was and failing. And so I dropped out of school. And that was pivotal because I was raised that when you start something, you complete it. And that meant that I wasn't able to complete something that I started. And that was hard and tough. And I remember calling my parents afterwards because they told me they were not going to pay for the post-bac. And I think because my dad kind of knew that I wasn't going to go to med school, they were like, good for you. I was like, really? And they both were like, yes, congratulations on being an adult. And I was like, okay. And so when I decided to do my doctorate, I knew going in that I wanted to do a postdoc because I knew as a woman that the disparity in pay for women and male faculty members was real. You know, we hear about it in the business sector, but I also knew that I would have more negotiation power if I did a postdoc. So when I went in for my doctorate, my faculty encouraged me to apply for tenure track positions right away. You know, like right when you got to dissertation stage and was finishing and stuff like that. And I knew that wasn't the path that I was supposed to go on. I'm also a spiritual person, and my faith in God told me that that wasn't how my career was supposed to be. And my career has never been like this. Like some people's career just goes straight up like that. They don't have any bumps, but mine has been like all over the place. And I was in my 30s when I went back for my PhD, which also to some is crazy because I quit my full-time job with benefits. I had another 6 months and I would have been vested by the University of California, but I just gave it all up to continue doing what I love. And I'm glad that I did because I wouldn't be here now. I wouldn't have met you. I wouldn't have been able to work at Mayo Clinic or University of Florida. You know, I'm just very thankful and it's humbling, but the path definitely wasn't what I anticipated.
Let's jump to our next segment. It is called Decision Do-Over. The reason I want to go there immediately is because you already made the case for there are careers which are linear and going up. And then there are careers like ours, which is a path that is how we draw anything. I would think, like not lines, but it's squiggly, it's up, it's down. And then you also brought in faith in terms of like knowing this is not right and then stepping away and then you having the support of your parents to say like, good that you figured that out yourself and they applauded you for that, which is great. So given, as you drew it, like squiggly lines in terms of careers, there's a lot of reflection moments. Are there any decisions that you'd want to do over on? Can you talk us through that moment?
You know, I don't live with many regrets. There are things that I would definitely do differently in my career that have impacted my home life. Like, for instance, I never had a career development award as a scientist. Like many scientists get these career development grants and things like that. Like I submitted some and they weren't good enough, so they didn't get funded. But what I would have done different during my time at Mayo Clinic, I would have written an R1 grant very early, and I didn't. I think that would have changed the trajectory of some of the things in my life now because it would have put me on a path to independence much sooner.
Just to pause and ask you, because not everybody listening would know what an R1 grant is.
So there are different grant types that the federal government funds. Right now is in a very unique place in our history with federal funding. But historically, there are different types of grants. The pinnacle or the most prestigious grant that a scientist can get is what they call an R01, and it's R01. And it's a independent grant, and the scientists can solicit for them, or there can be special calls by the federal government from the different institutes. It could be cancer research, it might be aging research, it might be heart, lung, any of the institutes. Many of them fund those types of research. And there's smaller grants as well. And then you have bigger grants that are multi-center grants and things like that. But this particular grant means you've arrived. And many academic medical institutions look for researchers to have that before they get promoted to sometimes associate professor or even full professor. So they're the pinnacle in the field that I chose to be in. And when I was at Mayo, they were very important, but Mayo also looked at different types of funding for promotion. So you could have funding from foundations. It could be mixed funding. You could partner with other labs and be more collaborative as a scientist. But where I am now at WashU is very traditional. And so these types of grants from the federal government mean a lot. And before my dad passed 9 years ago, he and I talked about it. Like, he didn't get to see me come back home. And when he was on faculty at WashU in the 70s, before I was born, his mentor got 4 R1 grants in the 70s, or what the equivalent was at that time. And he said to my father, this is going to change the trajectory of all faculty members that come after me. And he didn't lie. And it has, because now it's become the pinnacle of what's necessary. And the list goes on. It could be UCSF, it could be Harvard, it could be Hopkins, it could be any of the big players in academic medicine who are moving the needle towards quality healthcare and wellness in terms of research on and science that impacts human health. And I know now, in the times that we're in now, we are told to diversify our research, which is different than the marching orders in the beginning. And so now academic medical centers are trying to think very thoughtfully of what does that mean for a lab. And I call my research a lab. It doesn't have petri dishes. It has computers and people that go out in the community. And it's called a dry lab, because I don't like believing hard and soft science. I don't think that there's a such thing, because if all science was easy, then we would do all the science. And that's not how this works. But the one thing I would have done differently is try to go on that trajectory earlier, because then it would have set me up for other types of funding from the federal government and even foundations that I may not have been eligible for now because I didn't go down that path sooner.
Got it. And then you did mention diversifying the research, and you're using diversify from a financial portfolio terms.
Mm-hmm. Yes. I think that with scientists, we're told to go down the federal government path. That's the road most traveled. But we know that endowed dollars, so dollars from people that give money to scientists in their areas, are very important. Funding from state government. So the people that I trained with at the University of Toledo for my doctorate, many of them, they didn't follow the path of NIH. They followed the path of being good teachers and health educators and being public health practitioners, which is what I wanted to really learn, and therapists. And most of their funding came from different states to help with health improvement plans or foundations. And I needed to learn that too. But now I'm in this other place where I have to think very thoughtfully of what the funding looks like for my research program. And quite honestly, it's weird right now. And I usually don't use that term, but we're in a place where we're trying to make sure that we can grow and keep the doors open and expand, and what roles look like and how do we shift and who do we partner with and things like that. And it's like running a small business. And scientists aren't taught to how to run a business. We're taught to do the science.
Yeah, this is true. And it is important because you are negotiating, you are actually bringing in a team and then making them work. And then you also have to come up with what's the return on the investment, even in grant dollars. And with that context, because you brought this back to it's important for scientists to also have some business muscle that they can add on. Let's go on to our next segment called Vision Venture. So in Vision Venture, I know this is probably your favorite one. You're looking ahead towards direction of where your work is evolving, and what are you moving towards right now? What are the things that's on your plate that you would want to share in this segment?
So I think one of the big things for me is thinking about preparing community members to engage in research. It's been a big part of my research program for years. Oftentimes, community members don't have the capacity to be able to meet researchers. So one of the things that I'm really big on is bringing researchers to the communities that they want to do research with. I often think that we tend to do helicopter research where we go into a community, we draw some blood, we ask some questions, we do some surveys, and then we're out. And then they hear on the news that Dr. Such and so was promoted to full professor or has now retired. And yet a bulk of the funding that we receive for biomedical research is federally funded, which means it comes from tax dollars. So it's also being a good steward of that money. So one of the big things that I'm interested in is capturing community member stories about research, capturing their stories about their journeys to wellness and their journeys with diagnosis and treatment and the caregiving experience. I'm also interested in training the next generation of scientists and even people to mentor that next generation of scientists. As somebody that lives every day with neurodiversity, sometimes what my needs might be very different than someone who is neurotypical. And how do we help mentors prepare to work with those junior and even mid-career faculty members in a way that's very thoughtful to what our needs are without harm and causing trauma. The other thing that I'm really interested in is really entrepreneurship in science. I own a consulting company, and it's kind of like a baby consulting company because it really hasn't made any profits for real, for real. But I really want to look to see what does that look like for me having an academic home at WashU while also owning a business. And it's becoming more prevalent now for scientists to expand not only with the work that we do internally in academic medicine, but also to thinking about our fiscal responsibilities and growth beyond our labs, outside of the walls of academia. And I've had some pretty good examples of groups that have done that as well that I've worked with when I was at Mayo and now here at WashU, and now partnering with you, Pradeep, on some of the work that you're doing within your companies has been eye-opening for me. And I'm learning a lot of things that I never thought that I'd have. You know, I'm the little girl that couldn't read until I was 8. And so now being able to have these chances is more than humbling. And the funny part is my parents thought I could read because I would make my brother read to me, like read the same stories over and over, and I'd memorize what he was reading and then say the story and say, I think I want to make something up. And they were like, okay, go ahead and So, yeah, I kind of faked it a little bit. And at this stage of my career, I'm just ready to live out loud in a way that brings voice and wellness.
It's almost like you were executive ready back then because you had a team which is going to read and tell you whatever you had to do.
Yeah, my stuffed animals and my parents were like all for it. They were like, sure, make that story.
Exactly.
And I'd have them all lined up and ready.
So you brought in a few things, and I think we want to get a bit deeper on this. A few things, which is communities and engaging on the stories. There was a point you mentioned around these are our tax dollars and we want to make it to work. Can you elaborate on that? And I have 2 other points I want you to elaborate on, because that's, I think, a very important point that has to be elaborated and shared, because why is that a community dollar not working? And the way you're looking at it would make it work more for.
So I think that some of the times that, so when we pay our federal taxes, those dollars then go to Congress. Congress then has the Department of Health and Human Services that they give a line item budget to. The Department of Health and Human Services gives the budget for the Centers for Disease Control and Prevention, the National Institutes of Health, AHRQ, the Agency of Healthcare Quality Research, HRSA, the Health Research Service Administration, those 4 institutes. And then you have the Patient-Centered Outcomes Research Institute, which is an endowment, which is slightly different from the other 4. The other 4 also fund things like that R1 grants, or they might have federal contracts and other things like that. Well, that money comes from the dollars that we pay in our federal taxes, which make up the budget, right? And then some of that money that also goes for taxes paid for other things like defense, it pays for Centers for Medicare, Medicaid, a bunch of other stuff as well. But some of that, a portion of those dollars come from what we pay as citizens or residents within this country. And so I've always been in the mindset of, okay, well, if my tax dollars are going to this, then how is this going to benefit my community? And how is it going to benefit me? A big push years ago was there was an IRS change where people that participated in research had to pay taxes on their research that they participated in. And I was like, that makes no sense to me because our tax dollars fund research if it's a federal grant. So why are we now paying? It's like double taxes. But that's the IRS to answer, right? So I think that there's multiple points here. First, if we are getting dollars within our academic medical centers to do research with federal dollars, then we have a greater good of telling our community how that research is happening and to return results in a way that's thoughtful and appropriate and to disseminate our findings, not just in peer-reviewed journals or at our scientific meetings. And that's controversial because they're like, well, why am I going to go back to Mrs. Jones and to her partners or her friends and tell them what I've learned? But we wouldn't have any of this if it wasn't for Mrs. Jones and the collective of citizens that are paying into this pool. The other piece is I really do believe that we need to have more community voice at the table when we're funding science. So I mentioned the Patient-Centered Outcomes Research Institute, PCORI. So during PCORI study sections, and I've been a reviewer for them, I've been a PI that's been funded by PCORI, is that the scientist, the physician, or the healthcare provider, and the community partner, and possibly the business owner, all have equal voice at the review table. So it's not just a bunch of people that look like me making a decision on how research is funded for different communities or the different science that's moving forward. So for instance, I used to use this example when I was still teaching. If we're creating a new device to help with patients that have diabetes, but the device is the size of a dictionary and you're asking the patient to wear it, is that the right device to create? But if you don't hear from the patients or the community members on what their thoughts are, then are we doing the right thing as scientists? And the same thing can be said with drug development. So, for instance, there was a new drug that came out for Alzheimer's disease, and it required patients to go to an infusion center a certain amount of time, to have imaging tests done, to have blood draws done. Oh, and by the way, you need to bring somebody with you that stays with you at every appointment. And the cost of it was really, really high. It was like $56,000 or $58,000 a year. And we didn't know if it was efficacious in all communities. So they didn't do the studies and they didn't have enough to make general statements about all communities that would have been impacted by this new drug. Eventually, it did receive FDA approval, but then eventually it went away because it wasn't going to help the people that needed it most. The time that people needed in terms of care, of receiving the medication, the communities that participated in the trial, and all of these things matter. So it goes back to us being partners in science for health improvement. I can learn a lot from the pastor of the local church who's watching their congregation become older and people within that congregation being impacted by dementia because they might be on the spectrum of preclinical dementia or early onset dementia, but yet they don't know who to go to for care. And my job is to say, okay, maybe call this person at WashU. So I think that we have to think about science very differently. It's not just me coming up with ideas because he might have some. Or it could be the school teacher that might have an idea about something to do in her classroom. So we have to think more outside of the box and be good steward of the resources that we have.
Yep. And you bring in stories to be a way to unlock this within the community to help through. And I'm going to take us into puzzle point before I ask my question. So next segment is puzzle point. And puzzle point, we have discussions where it is about something that you are working on with a lot of unresolved questions underneath. I might argue everything you're working on has a lot of unresolved questions underneath. That's why you're working on them. Or that's something you even gravitate towards anyway, like uncertainty. Yeah, let me go in. It seems to be a theme. But let's go back to the previous comment that you were mentioning around bringing in communities, understanding what they truly want, being open for ideas that might come from the community, not the researcher or the thinker in an institution. coming in, and the context which how we are working on. And you even said like, hey, this has helped, or even helped you think through a few things and share what we are working on, or even some other puzzles that we are trying to work together in the context of answering a puzzle that you're working with that's unresolved, and how we are trying to look at it.
So I created with my community partners a research registry to help increase engagement of communities that were not engaged in Alzheimer's disease or dementia research. When I moved back to St. Louis, I had the privilege and honor of being my mom's caregiver. And one thing that I noticed is we would go to doctor's appointments until we ended up getting the right care team, that she really needed somebody there to advocate for her and be her voice, since my dad had passed, who was her caregiver, which sometimes happens. But I also noticed that this was happening with her friends, who were mostly retired teachers, some were retired judges, and the like, and their voices were being silenced. And so when I got ready to write the registry grant, I had worked with Dr. John Morris, who created the Clinical Dementia Rating Scale, who was the former director of the Knight Alzheimer's Disease Research Center. John recruited me back to WashU. He's now the co-director with Dave Holtzman, now being the director. John and I were talking about what does the participant pool look like of the research participants that engage in research at the Knight Alzheimer's Disease Research Center. And they were mainly wealthy, highly educated, and mainly white. Well, I'm none of those things. So I was like, what should we do? I said, we need to do something different. And he agreed. So we started the Health Disparities and Equity Core, which is now the Health Disparities Engagement Core, since we can't use the term equity in all contexts. And so we have now worked towards the goal of engaging those communities that have not been a part of our research. And so when I wrote the grant to the federal government, the first aim was to do a community needs assessment. And it was really, I hadn't lived in St. Louis in 19 years. My dad had now since passed, who had worked for the Missouri Health Department before he retired and before his death. So he usually would have a pulse on some of those things, but I didn't. And then plus, I'm nosy. I like hearing people's stories. I was like, well, maybe we could do these cafes. So we did these listening sessions, which were like what they call scientific cafes. And we called them brain aging cafes, where we provided education about brain health and Alzheimer's disease, and then said, okay, what do you know about this in your local community? Are people talking to you about Alzheimer's disease and dementia? Are you engaged or connected with healthcare providers? What resources do we need? And then we did a second piece within those same sessions to talk about how to engage in biomedical research. What is the role of the research participant? What is the role in connecting with different labs and finding studies and all of that? Resulting from those 14 engagement activities, we talked to a little over 300 people. And then from that led us to being able to recruit 1,000 people. But I also have a community governance board for my lab. And that is a group of individuals. Some of them are highly educated. Some of them are not. Some of them are CEOs of agencies. Some of them are scientists that work in the nonprofit sector. Some of them are peer scientists from WashU and healthcare providers at WashU. Some of them are healthcare providers in the community. And they keep me honest. Like, for real. Like, I say, I was thinking about, no, that will not work. Or, well, this is the concern I have with this research. Can we? And say, well, yeah, that'll work. Because I want to make sure that whatever we're doing is appropriate for the community in which I serve. Because I have to remember that while I work at WashU, I live in St. Louis. I go to a Black church. I go to a Black hairstylist. I go to dinner and lunch with my girlfriends at different places. My husband teaches it in one of the schools here in town. We are also a part of this community. And so I want to make sure that I protect my hometown. And I do that by engaging with people in my hometown to find out what's really happening.
And the work that we are doing, how are you planning on actually using that one?
So the work that we're doing with Stories and Wisdom, I think will be pivotal in us finding new ways to work with caregivers. I often think, having been a caregiver for both of my parents, Often I think our stories get lost, especially when you're in the sandwich generation of how do you balance work, your own partnerships or marriage, while you're also giving to people that you care about who need care. Because I'm now also caregiving for my mother's best friend who didn't have children and she had a stroke. And so making sure that she has what she needs. So I think the Stories and Wisdom platform will help us with that. I also think that another opportunity that we have is using that platform that you created as a mechanism to learn stories from people who have participated in multiple research studies. Like, what were their experiences that were good or bad? And how did that impact whether or not they decided to engage in other studies? And I also think that we can even do it. One of the other areas in my research lab is also that I focus on is women's health. And this is one of the reasons that my husband and I hadn't been able to have children is because I had endometriosis and uterine fibroids. And how can we use that to help women that are now going on the journey of menopause or perimenopause or other things tell their stories in a way that will impact how researchers and healthcare teams engage with them in a way that's important. So I think what you've built and what we're planning to do when funded will allow us to really gather stories so that we can create better interventions that are community and patient focused.
Yeah, it is an important part because I wanted people to start to understand how this comes back to creating solutions that impact people, community. And there is a feedback loop that is needed, which is what you found out. And then we are just a tool in terms of creating that ongoing feedback loop that doesn't feel like a survey because people don't like filling surveys, but leaning in with stories that others go like, wait, I thought that was just me. That happened to you as well. That is how we get that data that helps up with the solution. It is powerful.
It's very powerful. So one of the things I learned early on in my career as an epidemiologist is that people like to tell their stories. Like, you can ask them questions like, how many times a day do you eat? Have you been screened for this disease? Have you done this? And that's yes, no questions. It's dichotomous, and we label it ones and zeros in our databases and we run all the statistics and stuff like that. But somewhere in the middle is this gray area. And that gray area is the stories. Like, what led you not to get this screening? And there's a story in that you don't get just from asking survey questions or just by looking at somebody's biomarkers. There are other things that lead to how we live our lives and the decisions that we make and even the opportunities that we are afforded or not afforded. And so I think that the platform you've built and that we're planning to test with multiple areas will allow us to see that's gray pieces that you can't even sometimes get from focus groups, because it's a facilitated discussion to an extent, but it's also an opportunity for somebody to say, aha, this happened to me and this is what I did. Or, oh my gosh, I hadn't thought about doing that for myself or for my loved one or advocating. So I think that we're going to learn a lot in ways that will change people's lives.
Yeah, we've also seen where people hear somebody else's stories and it helps them even understand what happened to them.
Exactly.
Because sometimes when you ask people something on what happened to them, they'll state it in the ways they have been conditioned to. But when somebody else looks at it and then said, here's what happened to that individual, they might be strangers. We've consistently seen others go like, wait a second, that has happened to me, but I didn't realize that happened to me till you tell me what happened to you in a specific way. And an example that happens for most of us is in a situation that leads to parenting. And it need not be our own kids, like niece, nephew, still our own kids, the broader sense of it. That you go like, I've seen this track before, but when it happens to you within your community, suddenly you need somebody else to parse that for you.
The same thing happens with caregiving, for real. With my dad, my brother was the one who was, and mom were the ones that were really his primaries. And then I would fly into town and just ask a whole bunch of questions to his oncologist and things like that because he passed from cancer. With my mom, I had a group of girlfriends that were also caregiving for their mothers around the same time. Some of them still caregiving. And we were able to swap stories. And then her last, one of the physicians on her care team was also caregiving for her mom and dad. So we ended up having this bond where we could say, and then one of her last physicians, Dr. Cummings Vaughn, her father passed a year ago last month. She and I developed a friendship. And she was also in academic medicine. So we could also have stories about the grants we were working on or the papers we were doing and the managing households and things like that. But I think with caregiving, I noticed the same thing. And someone on my team, I was with her when her mom passed, who was a friend of my mother. I was in the room. And she had helped me get a senior apartment for my mother's best friend after her stroke. So you build these communities, and I think it's the same thing with people with kids. Like you build a community around that stage of your life. And I think the platform that you've built will allow us to build community very differently.
That's our hope as well. Let's go to our next section. And that next segment is called Game Break. This or that, and this is obviously the Joy edition. I'm going to give you just 2 phrases or 2 words in some examples, and you just choose one. And if you want, you can explain, but you don't have to, because it's really about us having a rapid fire segment. First one, classroom or community setting?
Community.
Listening first or teaching first?
Listening. And that's hard for me.
Preventative care or clinical treatment?
Preventative care.
Oh, deep focus work or collaborative sessions?
Can it be both? I think it's collaborative sessions would be the primary.
It helps get the data for the deep focus work, yeah.
Exactly.
Yeah. And with that, our last point, data or stories?
Now, I want to say both, but I'm going to say stories. Because stories get us to the data.
So, Joy, thank you for sharing the work behind the work and the passion behind the work and the work that drives the passion. Like everything is almost circular or a polygon with you. And more importantly, reminding us that, equity isn't an abstract idea. You live it, you practice it. And with all of your narratives, like it comes out very clearly, like community is what you're in the middle of and what you're working and touching and engaging and living. And it's very important for you. Where can people learn about your research, your talks, and the work you're leading at WashU?
So all of my social media pages are open. So Instagram and things like that, WashU's website. And I am on LinkedIn. I do have a website, but we are in the process of restructuring. So once we get back and up and running, then the Ballsbury Lab website will be back open. But right now, probably social media or contacting me through the university or LinkedIn.
Brilliant. And to everyone listening, thanks for joining us. Thank you again, Joy, for being on the Stories and Wisdom podcast. It's been wonderful.
Thank you.
And for everybody listening, we'll be back with more conversations that explore the stories behind the people doing very important work in our community. See you soon.
Playfulness and curiosity.
This new superpower called persuasion.
They're the rules of the world, and then here's the rules for us.
Real deep pink.
That was a very different level of inequity.
What does rich mean?